Cool. We're here today with Chris Wakeman. Chris, you're a colorectal surgeon at Christchurch Hospital.
Yeah, that's my main specialty. I trained as a general surgeon and then specialised overseas learning colorectal surgery. I've been back about 5 years now.
Okay. And your interest in particular is colorectal cancer, isn't it?
Yes, that's the main thing. And also hereditary colorectal cancer as well.
Okay. And you came today to the conference here to give 2 talks, wasn't it? The first one was on management of colorectal cancer. And then the second talk you've just done now is on case studies related to GI bleeds. Do you mind if I start with colorectal cancer?
Yep.
It's a common thing, but it's killing people, isn't it?
It is common, yeah. So it's about, if you look at incidence, is about, for most males and females, about a second or third most common cancer. But so prostate or cervical cancer and breast cancer in women are more common, but they don't tend to kill you. So bowel cancer is a real problem because it can present late and lead to death.
Right, okay. And what's the kind of types of bowel cancer that you've been finding? You were talking earlier about hereditary and...
So about 80% of bowel cancers have got a sporadic or don't have a familial, you have no family members that have it. And about 20% you'll have a family history, and then only about 10% of those will actually find a hereditary condition. And maybe that the other 5% in the future will have more sensitive, better tests, and we might find a reason why. We do have, quite a few members of Lynch syndrome in this country, which is autosomal dominant. So that's really important to the whole family because it's common in the family. Then if it's autosomal dominant, half your siblings will have it, for instance, on odds.
All right. And is that a common one, or is it something I haven't quite heard of before?
Lynch syndrome is not. Yeah. It causes about 5 to 7% of all bowel cancers.
Okay.
But there's also Lynch syndrome can cause what we call extracolonic cancers as well. So uterine cancer and ovarian cancer can be associated, brain cancer, and some urothelial cancers as well are related.
Okay. And so if a patient presents to a GP with symptoms, when should they be doing these referrals to you?
Well,
or they do the investigations and then...
They should be thinking, they're presenting with bleeding, for instance, they need to start working out, is it significant bleeding? Do they need a colonoscopy or a CT scan, CT colonoscopy to investigate that?
Yeah.
But I think it's important to go back to Lynch syndrome for the GP to also be thinking about these things, to taking a family tree.
Yeah.
Are there 3 members of the family or more with bowel cancer or these extracolonic cancers? Are they young? And then referring on, because as I say, it's not just that index patient who's important, it's the whole family we've got to think about. So
doing the background history first, trying to find the other family members that may have a connection to this, and then getting you involved after that. It's pretty important.
Yeah, really important. Yeah. I mean, it gets referred on to the familial bowel cancer service, and that's part of our job, is tracking down all the family members as well and getting them tested. But doing that first line history, which prompts everyone to think, there's 3 members here, we've got to be a bit more concerned, is a good start.
Okay. All right. And the other case you had was your GI bleeding cases that you just did a workshop on with some people. What did you cover in those cases?
So I covered a lot of the major causes of GI bleeding, so things like, just simple things like hemorrhoids. So we talked a bit about proctology, so anorectal type conditions as well. We talked about anal fissures, again, which is a common cause of bright red painful bleeding. We talked about colonic things such as ischemic colitis and angiodysplasia of the colon as well. So we went over a whole variety of cases and causes. It was 45 minutes to an hour of bit of random.
Slowly moving up the bowel as you were going, by the sounds of it. Okay.
With some horrible photos of bottoms.
Oh, is that right? Yeah. Okay, so like banding and things like that you're talking about.
Yeah.
Okay. And what's some key messages that you have for GPs in particular? If someone does come in with PR bleeds, I guess you've got to rule out if it's a fissure or a hemorrhoid or things like that. Is that right?
Yeah, so taking a history, finding out what the blood's like, how often it is it significant that it needs further investigation, which is a really hard call for GPs.
It is.
And then how to battle the DHBs to get a colonoscopy for those, especially the 45-year-olds, so they're not quite old enough to be really worried, but is it significant? it's a hard call.
Because
So
it's
trying to-
outpatient as well, isn't it? It's not inpatient, you can't get it done straight away.
Yeah, and
Yeah.
you know, some DHBs have long waiting lists for colonoscopy, so it is hard. But taking a good history, examining the patient, do they have a local anal problem, or which explains it, or do we need more investigations?
Okay, cool. Well, thank you for coming in today, Chris, and having a chat with us and sort of giving us a summary of what you've been speaking about here at the conference. It's definitely interesting. Yeah.
Okay, thank you very
Thank
much.
you.